Hi, good evening. I would like to welcome everyone to the Baltimore County Fire Department EMS Academy Training Series. Tonight's speaker is uh, Dr. Christian Popa. Dr. Popa is a retired colonel from the United States Army, having been stationed pretty much the majority of his career, if not all of it, at Walter Reed Army and National Military Medical Center complexes down in Bethesda and Washington, D.C. Dr. Popa went to the Uniformed Services University of Health Sciences, where he got his medical degree, and then he did an internship at Madigan Army Medical Center, followed by an anesthesia residency at Walter Reed Army Medical Center and a critical care fellowship at Walter Reed Army Medical Center. He remained there as staff, became the chief of critical care medicine, and where he continues to work to this day. He is certified by the American Board of Anesthesiology, and he is a board examiner for the American Board of Anesthesiology. Tonight's topic is going to be on heat and cold injuries, and without further ado, I welcome Dr. Popa.
Thank you, Jeff, and good evening, everybody. So we're going to spend the next hour or so talking about heat and cold injuries and identifying and treating them. So let's go ahead and get started. Make sure that my slides will switch. So our objectives for today is to identify risk factors and specifically identify and manage heat exhaustion and heat strokes. And I'm also going to talk about frostbite and the management of hypothermia. So I'm going to start with some data from the National Weather Service, and they put this out yearly. So the last year available is 2023, which is in red. And what I want you to notice is that heat injuries by far and away are the #1 killer of all weather events. Things like floods, lightning, hurricanes tend to get a lot of publicity and they tend to cause a lot of economic damage, but the mortality is actually quite low. In contrast, cold weather injuries are less common and fatalities are relatively rare. The other thing to notice is in blue, you have the 10-year averages, and in yellow, the 30-year averages for this data. And these numbers have been remarkably consistent over the last 30 years, despite FEMA, despite improvements in technology, despite in the fact that we've gotten better at responding to these events. So a little bit of physiology, and I promise that I'm not going to delve too much into this, but it will apply to some of the things we talk about. In terms of thermoregulation, body temperature is very tightly controlled. There's normally about a 1 degree Celsius diurnal variation, and we tend to run a little bit warmer in the evening. The temperature control centrally is from the hypothalamus, and the anterior hypothalamus regulates all the autonomic responses, which regulate our temperature and is about 80% dependent on core temperature. Peripheral input has a small effect on the autonomic responses. In terms of thresholds, even a 1/10 degree increase in temperature above what we are used to as normal will kick in sweating and vasodilation. A 0.3 degree drop will kick in vasoconstriction. Non-shivering thermogenesis starts at 36 degrees, and frank shivering starts at 35.5. So the body maintains very tight control on temperature because it's important to mediate all the chemical processes that support life. The posterior hypothalamus is also very important, and it integrates both central and peripheral sensory input, and this regulates behavioral responses. So the posterior hypothalamus tells us to get in from the cold when it's cold outside, to put on a jacket when we start shivering, to get indoors when it's very hot. All of these protective mechanisms, they keep us out of trouble. Peripheral thermoreceptors are less important and are mainly concerned with detecting cold and cold injuries as opposed to warm temperatures. There's 10 times as many cold receptors as there are warm receptors, and they activate over a wide range of temperatures, whereas warm receptors operate only at 30 degrees. So their main role is to immediately initiate reflexes such as shivering, decreased blood flow, decreased sweating in response to cold input or peripheral exposure to a cold environment to limit heat loss. And this will become important in some of the treatment modalities that we talk about. How do we exchange heat with the environment, both in terms of gaining and losing heat? By far, the biggest source of heat gain or loss is radiation to the environment that we're currently located in. So about 60% of heat transfer occurs by gain or loss of heat waves. And this is why we put infants in incubators. This is why people wear multiple layers of clothing to create a warm layer of air around them to limit heat loss. Most of this effect is by far radiation. The second most common and important mechanism is evaporation, actually. And about 20 to 27% of heat is lost through insensible evaporation from the skin and lungs. Every time you take a breath of air in, it's 100% humidified. And even when we're not perceiving that we're actively sweating, we'll lose about half a liter of sweat, basically, through insensible evaporation daily. And that can increase dramatically if we need to cool the body. Obviously, this total amount is dependent on what sort of environment we're in, what the temperature is, and whether it's a humid or a dry environment. Conduction to air is relatively minor, even in cold environments. Similarly, conduction to objects is very minor. However, of note, conduction becomes very efficient in water. So wet clothing will increase heat loss 5-fold, and immersion in cold water will increase heat 25-fold, which is why even short-term exposure for a couple of hours to mildly cool water at 60 degrees is enough to cause fatality in most cases. Air currents, convection are a little bit variable, but likewise tend to be a minor player in terms of heat gain or heat loss. So the biggest two mechanisms are going to be radiation and evaporation. So with that, let's talk a little bit about heat injuries. So this is a chart looking at air temperatures and the perceived heat index or wet temperature index in relation to the humidity. So our main mechanism to protect ourselves from overheating is sweating, and obviously that's significantly impaired in humid climates. And the reason I bring this up is Maryland actually has two climate zones. So Eastern Maryland is considered to be a humid subtropical climate, and Western Maryland is a humid continental climate. And the average humidity in Baltimore right now is about 65% and will increase to about 85% during the peak heat months of August and September. And as you can see on this chart, when you get into the mid-90s at 80% humidity, you start getting into the extreme danger zone for heat stroke or sunstroke. So even moderate activity and longer than brief exposures to this environment is enough to put somebody at risk, especially if they have risk factors. Obviously, you can tolerate higher temperatures a lot better at lower humidity. Which is why it feels oppressively hot in Baltimore, even though it's relatively hotter than, let's say, Phoenix. So another important point is water loss. So most heat injuries occur through dehydration, which impaired the body's ability to sweat and cool. And with light activity, typically we lose 2 to 3 quarts of water daily. However, in a hot environment, that can increase to 6 to 8 quarts. And your max sweating rate at extreme physical exertion is 2.1 quarts per hour. And the problem is, even if you are compulsive about drinking water to try to keep up, the max rate of water absorption from the gut is 1.5 quarts per hour. So in a very hot environment at heavy exertion, you're going to fall behind. And the longer that goes in, the more you tend to fall behind. And in terms of the effects, 2% body water loss is enough to affect strength and coordination. 4% starts affecting things like balance and endurance, and 5% water loss is enough to cause heat exhaustion. And beyond that, you very quickly progress into delirium and system failure, which are the key components of heat stroke. And the reason that's important is once you get to the 7%, you start getting altered sensorium and you lose the ability to perceive that you're in trouble or that you're overheating and getting dehydrated. And unless somebody's keeping an eye on that individual, they will very quickly progress to heat stroke and will be unable to help themselves. The other thing to note is the thirst mechanism is relatively insensitive. So by the time somebody actually gets thirsty and feels the need to drink water, they're already several quarts to several liters behind in terms of being dehydrated. So the recommendation in a hot environment is to drink a cup every 15 to 20 minutes, even if not thirsty. Things like alcohol and caffeine and soft drinks have a diuretic effect and impair vasodilation and sweating and will make any sort of heat injury potentially worse, as well as increase the likelihood. So conditions which increase risk of heat injury, extremes of age. The very old don't sweat well. They don't have the cardiorespiratory reserve to maintain adequate blood flow to the periphery to cool or to stay warm. And they have a lower metabolic rate, so they're going to be at higher risk of heat injury. Likewise, if you live alone, there's nobody there to keep an eye on you. So if they get dehydrated as they begin to have altered sensorium, they lose the ability to protect themselves, and there's no one to rescue them. Access to air conditioning, I'm going to touch that one in a little bit. Obese patients are going to be at higher risk because they have a bigger surface area, or sorry, body mass to surface area, and have impaired heat loss. Things like dehydration, alcoholism, hyperthyroidism increases metabolic rate. Physical conditioning and cardiovascular disease are important because they limit the blood flow to the periphery and the ability to dissipate heat. COPD likewise does the same, and diabetics have microvascular disease, so they have decreased ability to sweat and decreased ability to vasodilate. This study came out last year in JAMA, and it was an interesting study. So what they did here is they took 18 elderly patients and looked at their core temperatures while exposed to a hot environment without air conditioning, with no fan on, a fan at 2 meters per second and a fan at 4 meters per second. And the important thing is there was absolutely no difference in body temperature, whether there was a fan running at slow or fast speed or no fan at all. The patients did feel more comfortable in terms of their thermal discomfort, but the body temperature stayed the same, and actually the fluid loss increased because of a little bit of increased evaporation with the fan on. So a lot of older people don't have access to air conditioning, live alone, and the fix, if they don't have air conditioning, is to run a fan, and unfortunately it is not very effective. So it doesn't really protect them from heat injury. Children also deserve special mention. Infants are extremely vulnerable to changes in temperature. They have no ability to sweat, essentially. They have no ability to shiver. They depend on brown fat for thermogenesis, which is not very effective. They can't complain that they're too hot or too cold, and they're not able to remove themselves from hot environments. So, you hear all the horror stories of young kids being left in a car, and it always ends up tragically because of this. And in fact, the children under 2 years of age will have suboptimal thermoregulatory control and will not even be able to vasodilate or vasoconstrict effectively in response to changes in environmental temperature. Likewise, kids have a higher metabolic rate. They have an increased body surface area to mass ratio. They don't acclimatize well, so they are essentially a setup for hot and cold injuries. And any older kids who have decreased ability to sweat. So these are kids with cystic fibrosis, kids that have paraplegia or quadriplegia, and rarely you have kids that have congenital anhidrosis and lack sweat glands. So all of these individuals are at very high risk. There's likewise a whole bunch of medications that increase risk of heat injury. So Alcohol alters sensorium, so you don't protect yourself as well. It will dehydrate you, and it will alter vasomotor tone. So it will increase the likelihood of injury. Amphetamines, cocaine, tricyclics, all of these are vasoconstrictors and increase metabolic rate. Thyroid agonists likewise increase metabolic rate. Sweat glands are under adrenergic innervation. So alpha adrenergics cause peripheral vasoconstrictions. Beta blockers basically block the beta adrenergic innervation of sweat glands, so they function less effectively. Calcium channel blockers and beta blockers basically limit cardiovascular function and reserve so that you can increase blood flow. Antihistamines will decrease sweating. Diuretics and laxatives will draw you out. So whole list of medications that you commonly encounter in the patients that you take care of that put them at risk for these injuries. So I'll touch on heat cramps and heat syncope briefly. So one of the mildest forms of heat injury is heat cramps. And these are caused by excessive sweating in a very hot environment. And sometimes the individual will have abnormalities in sodium or potassium before they start falling behind in volume and becoming a risk for heat exhaustion. So with sodium and potassium depletion, they start getting severe pain and cramping in their legs and abdomen. They may vasodilate to an extent where they may feel faint and dizzy, and they typically will have profuse sweating and a severe headache, which are sort of early precursors for heat exhaustion. So other things to consider in this setting are diuretic abuse, potential electrolyte abnormalities that are baseline and independent of the heat cramps. And usually adults will be able to tell you about this, but in children, consider the possibility if they're outside of something like black widow spider envenomation, which also will cause cramps. These folks, this is sort of a warning sign in terms of the body telling you that it's starting to overheat. They're not in trouble yet, so simple management with rest and salt replacement with a salt-containing oral rehydration solution, something like Pedialyte or Gatorade, something along those lines, and a little bit of gentle stretching is all they need, and they should recover fine. One important point, though, is if they go back to doing any sort of strenuous activity too early, they are at significantly increased risk of progressing to heat exhaustion and potentially heat stroke. So if somebody actually is overheats enough to get heat cramps, they probably should take it easy for the next 12 to 24 hours before being subjected to a hot environment again. Another fairly common heat injury is heat syncope or fainting. And what happens here is, again, they're exerting themselves in a very hot environment. And in an effort to maximize heat loss, they vasodilate enough to where they actually drop their blood pressure and decrease blood flow to the brain. So they pass out and the body basically puts itself in a horizontal position to restore blood flow to the brain. Dehydration will significantly worsen this problem, as will things like alcohol. And it typically will often happen after running or heavy activity because blood flow is returned back from the legs to the body by the skeletal muscle pump. And when they stop suddenly, so if they're vasodilated, they will have decreased return and they will pass out. Again, they're not in real trouble yet, so management is relatively conservative. They should lay down or sit, preferably in the shade. If they are still dizzy, they should lay down completely, elevate the feet, and rehydrate them with some sort of salt-containing solution. So you can use, again, Pedialyte, you can use Gatorade or a similar type of sports drink. And if you don't have that, you can make a commercial rehydration solution, half a teaspoon of salt with half a teaspoon baking soda per quart of water. If you don't have that, just 1 teaspoon of salt in a quart of water. And again, very important, the person should not engage in vigorous activity for the rest of that day because if they recover and they go back to doing what they were doing before, they will be very high risk for going on to heat exhaustion. It takes a while to restore the body's fluid balance. So in terms of things that are potentially more serious, the first one is heat exhaustion. So here there is profound loss of both water and salt from the body due to exposure to high temperature and humidity. And usually this occurs over a multi-hour period. And again, even with relatively compulsive water drinking in a very hot environment, the individual is going to fall progressively behind in terms of their fluid balance. Once they lose more than 5% of their body water volume, they're going to have impaired ability to use sweating as a cooling mechanism, and their temperature will start to climb. So symptoms of heat exhaustion, they're going to have a very severe headache. They're going to have nausea. They're going to have fatigue. They're going to start having dizziness, which may progress to, towards delirium if not addressed promptly. Of note, the skin, they're still going to be sweating at this point. So the skin is going to feel cool, pale, and wet, and they will have dilated pupils. And usually, again, they're conscious, but will have an altered sensorium. And of note, with heat exhaustion, the core body temperature should be less than 102. So this is a little bit more serious. So again, they may need ABCs depending on their blood pressure and level of consciousness. Supplemental oxygen is good. And you want to keep a close eye on core body temperature, tympanic membrane, as opposed to skin temperature, which will not be reliable. And if they don't improve in the next 20 to 30 minutes, or if the temperature goes over 103, then they should be treated for a heat stroke, which becomes a medical emergency. And otherwise, get them to a cool environment, intravascular volume repletion. So again, this is serious enough to where just simple drinking will not be adequate. IV fluid will work best, preferably cooled. And again, the recovery period now becomes a little longer. It's up to 48 hours before they're able to resume any sort of heavy exertion. Otherwise, they become very high risk for a heat stroke. So we'll talk a little bit about heat stroke. And in heat stroke, you have more than 7% water loss, and you've lost the ability to sweat, maintain body temperature. And at that point, the temperature, their temperature goes very high and begins increasing exponentially. So unlike heat exhaustion, with heat stroke, they're going to have dry, hot skin. Of note, with heat exhaustion, the pupils are dilated, and with heat stroke, the pupils become constricted. They will have a severely altered sensorium, which will rapidly progress to unconsciousness. And again, the temperature will be very high, typically in excess of 105. So anybody that's over 103, or anybody that was less than that, it doesn't improve in 30 minutes, the measures should be treated as a heat stroke victim. So a little bit more in terms of the symptoms. So peripheral vasoconstriction, they're going to have a very high pulse because of the temperature elevation and the dehydration. They're going to be tachypnic. They're going to have very decreased urine output, very hot temperature with hot, dry skin, severe changes in mental status, and small pupils that are unresponsive to light. Once they progress to heat stroke, even with prompt treatment, mortality is in the 17 to 70% range, depending on the type of heat stroke and their age and comorbidities. And again, this is due to excessive loss of salt and water and inability to regulate heat once sufficiently dehydrated. There are two types of heat stroke: non-exertional, which is mainly due to prolonged exposure to a hot environment leading to impaired heat dissipation, and exertional heat stroke, which is somebody that's exercising heavily in a hot environment and despite maximal sweating is not able to regulate their body temperature and they have excessive heat production. Death and permanent neurologic sequelae are possible with both types. and immediate recognition and treatment are critical to try to limit this morbidity and mortality. And again, even with best care, mortality was going to be probably in that 17 to 70% range. So the classic or non-exertional heat stroke is from impaired heat dissipation and dehydration in a warm environment. So this most commonly occurs with the elderly, infants, and very young children. People who are not able to protect themselves and take measures to get out of this environment may not know to drink water, may not physically be able to get to it or have access to it, and progressively become more dehydrated. So this tends to develop more slowly, usually over a period of days, and presents with severe alterations of mental status, severe tachycardia, hyperventilation, and severe GI. And this is different than exertional heat stroke. This is typically found in adolescents and young adults who are exercising vigorously. This is the 20-year-old that runs a marathon in 100-degree weather, or is sprinting, or playing football or some other vigorous activity. This tends to develop very rapidly, and this shows up with a severe headache and an altered mental status a little bit faster. They may pass out due to volume loss and excessive vasodilation. And unlike traditional heat stroke, here rhabdomyolysis and DIC tend to be much more prominent and will rapidly progress to cardiovascular collapse and coma if not promptly addressed. So some basic differences between classic and exertional heat stroke. With the classic, because of the volume loss, anhidrosis or a lack of sweating is typically more common, and they will have organ failure, but rhabdomyolysis is less common as opposed to the exertional, which typically presents with rhabdomyolysis, acidosis, kidney failure, and coagulopathy and DIC. Of note, because this group is typically young and healthy, if they get through this, they actually will have a full recovery and relatively good prognosis. These folks, because they tend to be at the ends of the age spectrum, because they often have comorbidities, and because CNS injury is much more likely, typically have a much worse prognosis. So in terms of management, like every other medical emergency, the first thing is ABCs, airway, breathing, and circulation. So usually the sensorium or level of consciousness is severely altered. So they often will need intubation to protect the airway, and that will facilitate things like neuromuscular blockade, which will facilitate cooling. And then they often will need hemodynamic support. And typically, the best outcomes occur when cooling is initiated right away within 30 minutes of them going into heat stroke. So the sooner you get them out of the hot environment, the sooner you initiate cooling, the better their chances of surviving and having a reasonable neurologic recovery. So you want to monitor them with continuous rectal core temperature. Again, if they're in heat stroke, the temperature is going to be greater than 103. So a couple of points. One, your goal temperature is not going to be 98 or 98.6 because you're typically going to overshoot, and that results in hypothermia, which is going to make matters worse. You just want to cool them enough to get them out of immediate trouble. So the goal temperature when you cool is 101 to 102. And if you are able to initiate cooling immediately, i.e. through water immersion or one of the methods we'll talk about, ideally you want to cool them 15 minutes before transport to get them out of that critical danger zone. Otherwise, if you're not able to do that, do the best you can in terms of cooling them during transport and get them to a facility that they can take care of them. And we'll talk about the various modalities that are needed. So one of the simplest things to do is to get the patient out of the hot environment and put them in an air-conditioned room. However, I want you to know the rate of heat loss for that. It's actually very terrible. because as soon as they're put in a cold environment, those peripheral receptors in the skin are going to kick in and they're going to stop sweating and actually vasoconstrict because those receptors are going to register in that cold environment. So that actually does not work that well. What works best, if you can, is evaporative cooling with fans and misting using warm water, not cold water, to prevent vasoconstriction and to prevent that inhibition of sweating. So what you want to do is spray cool water to warm water on them while fanning warm air over them. And that actually gets you cooling rates of 0.5 degrees Fahrenheit per minute, which is actually pretty good. Simpler things you can do that also may help is putting cool or cold saline bags to the neck, groin, and axilla where you have large blood vessels close to the skin. If they're too cold, again, this may initiate shivering and vasoconstriction and may limit the effect. I mentioned water immersion because it's faster than trying to set up evaporative cooling. And here, if you can place the patient in a body bag or a tarp or essentially in a sheet or anything that you can use and fill that with water and ice, you're going to get some vasoconstriction, but it will still cool them. And if you use temperate water, you get 0.11 degrees Celsius per minute. If you use cold water, you get 0.16 to 0.2. And if you use ice water, because of vasoconstriction, it's actually not much better than using cold or even temperate water, but you will get some cooling. Again, the best thing you can do and the fastest is to spray cool water on them and use a fan with hot air to evaporate that off of them. You can try giving them IV cold fluid, but for the most part, even though dehydration is a component of this, they're not that dehydrated and they're also a risk for pulmonary edema. So you want to be careful with the total amount of fluid you give them. So the non-exertional heat stroke patients were just simply working out too hard in a hot environment and are overheated and more as opposed to dehydrated. So they typically don't require a whole lot of volume replacement. Exertional heat stroke may require 2 to 3 liters of crystalloid, but again, it's often an older population with limited cardiac reserve. A lot of times they're young kids, and regardless, for the most part, they're not going to need liters and liters of fluid. So be careful how much fluid you give them. They're almost always going to have delirium. So remember the other common causes of delirium. So you want to check a bedside glucose in case hypoglycemia is a component, in case it's too much insulin. Consider alcohol because it's often a confounder. And if you have it, give them Thiamine and a banana bag. And also Narcan if there's any chance of opioid overdose. Endotracheal intubation is often required, and typically they're going to be full stomachs, so they will need a rapid sequence. If you have the option, use rocuronium for paralysis for 2 reasons. One, it will not release potassium from inside cells, unlike succinylcholine, and because dehydration or rhabdomyolysis often result in potassium release and high potassium levels are going to be at risk for a hyperkalemic arrest if you use succinylcholine. The other thing is rocuronium is going to last 30 to 40 minutes, which will prevent shivering during the most active phase of the cooling process. And you can use additional sedation with benzodiazepines, which also help reduce shivering and will protect against seizures and have some experimental evidence of being neuroprotective. And likewise, maintain a high minute ventilation because it will help clear the metabolic acidosis that has developed as a result of the heat stroke. Things that can happen with this process and why is it so deadly? CNS damage is very frequent and will occur in up to 20% of cases permanently, and tends to have a very poor prognosis. Likewise, the heart is rapidly damaged, and there's going to be a risk for arrhythmias, cardiomyopathy, sudden death. DIC and rhabdomyolysis are going to result in severe hyperkalemia, acidosis, renal failure from the rhabdo, and dehydration. And likewise, they are very susceptible to severe liver injury and liver failure as a result from the heat stroke. So that's all I have on heat injuries. Let's pause here for a moment. Any questions for right now on the things talked about briefly?
Chris, what about febrile seizures in kids?
For the most part, they are relatively benign. One important point to remember is that protein begin to denature typically at 42 degrees Celsius. So that's the danger zone where you start being at risk for CNS injury, which can rapidly become permanent if the process is not reversed. So, anything that's starting to get into the 40, 41 degree range should be considered an emergency, and probably cooling should be initiated.
Found on EMS calls with kids where I've literally sprayed them down in a sink.
Yeah.
And that's broken the seizure for, again, it helps with the distribution of the heat.
And kids actually do well with spraying them down or cold water for two reasons. One, they have a lot of surface area relative to their body mass, so they make good radiators. The other thing is they don't shiver nearly as effectively as adults, so they don't vasoconstrict as effectively as adults, and they have a high cardiac output. So all of that leads to better temperature exchange. So, but yeah, spraying them down, putting cold saline packs, axilla and groin, wet sheet, fan, all of those things are going to be effective and more effective in kids. Any other questions for right now? All right, so let's talk about cold injuries a little bit.
There's questions in the chat. The first one is, the patient is vomiting. Wouldn't that be heat exhaustion and the patient should be removed from the field? Or the activity for the remainder of the day? You got it?
Yes. I would say in the right context, yes. So obviously vomiting has a very wide differential. Could be anything from food poisoning to narcotic withdrawal to you name it. But if the person's in a hot environment, if they've been sweating profusely, typically if they've progressed to vomiting, there will be a severe headache at least, and probably an altered sensorium. So if all those things are present, I would check a temperature on them, and if it's elevated, then I would give them the benefit of the doubt and treat them for heat exhaustion. And let's see, do you recommend misting fans in high humidity environments? Yes. They will work less well, but it's still the best thing that you have. And they will still be more effective than cold water immersion, which is going to be limited by those, by peripheral activation and vasoconstriction. Let's see, what about risks to firefighters in turnout gear hazmat suits? Yes, that is a real risk. And we have a similar issue in the military with the nuclear, biological, chemical protective suits. And the reality is, if you're in a hot environment, those suits you're not gonna be able to use sweating effectively because you're gonna sweat inside the suit with minimal evaporation. You will overheat. So you basically have to be aware of how much time you're spending in that suit, and balance what you need to get done versus the risk of a heat injury. I don't know that there's a good way around that other than to limit the exposure as much as possible. Any difference between wet bulb temperature and heat index? No, the wet bulb temperatures chart I showed you guys with the relative temperature that's perceived by the body as a function of the actual temperature and the humidity. August average humidity 75. Some sources would say 80, but yes. And again, that's why Maryland is classified as a humid climate. Fun trivia fact, what's the most humid state in the country? Any guesses? It's actually Alaska. Alaska has 77% average humidity year-round. Florida's number 2 on the list. Luckily, they're cold enough; it's not a problem. But Maryland is in there in the top third in terms of relative humidity. Wouldn't the misting fans compound the heat retention? Actually, no, because the fans increase convection and basically increase evaporation. And typically, when you're using that, you're using a victim of either heat exhaustion or heat stroke. They're going to be dehydrated in either case and have mildly to moderately decreased sweating. So misting basically substitutes for their impaired ability to sweat. Let's see, what else do I have? Does that answer everybody's questions?
Seems so.
Hey, Doc.
Sure. Hi.
Just wondering, which is better, Pedialyte? Do you recommend that over Gatorade and other electrolyte replacements?
Pedialyte is better for kids. It's perfectly fine for adults. If you have Gatorade's design is more of a sports drink, and it has more sugar, a little bit more sugar in it. Otherwise, I think the electrolytes are roughly the same. I don't know that it matters much. For kids, if you have it, I would use Pedialyte. For adults, if you have either, it's going to work great. So, but let's see. All right. So let's shift gears a little bit and talk about cold injuries. Again, less of a problem and even less so in Maryland. So similar to heat injuries, there are some susceptibility factors, and a lot of these are the same ones that we talked about for heat injuries. A lot of cold weather injuries tend to cause permanent vascular damage. So one susceptibility factor is somebody that's had a previous cold injury. And one manifestation of that long-term is Raynaud's phenomenon. So these are individuals where if the extremities are exposed to cold, go through a characteristic color change where they vasospasm and initially turn white. And then as they begin to get ischemic, turn blue. And eventually they'll have a rebound hyperemia and they will turn red. So because these people already have impaired peripheral circulation, they're very susceptible to cold, and they're very susceptible to cold injuries. Alcohol and nicotine, again, impair vasomotor function in the extremities. And our risk factors, inadequate nutrition will decrease metabolism and decrease cardiovascular reserve. Sweating will lead to clothing getting wet and significantly increase heat loss. Under activity, obviously, you're not generating as much heat. There's a certain amount of acclimatization that can occur in a cold environment. So somebody who's going from Florida, let's say, to Alaska and hasn't really transitioned in will be at higher risk. There's some ethnic and geographic variabilities. Obviously, Eskimos are much better adapted than the rest of us that living in a cold environment. Age, physical stamina, and then exposure and clothing and equipment. So I'm going to deal mainly with frostbite, immersion, and hypothermia, but there are other things that get lumped under cold injuries, such as chilblains, which are lesions that could occur on skin exposure to cold environment, carbon monoxide poisoning, snow blindness, sunburn. So talk about frostbite a little bit. So skin will freeze when the temperature drops to 28 degrees Celsius as below. So 32 is freezing, but there's enough salt in body fluids to where the skin will not freeze till it drops down to 28 degrees. As tissue begins to freeze, a couple of things happen. So ice crystals start to form in the cytoplasm. The cell membranes get leaky, and extracellular water begins to enter cells, followed by extracellular salt. The cells begin to swell, and eventually they will rupture. As the tissue thaws out, there is more salt that enters the cells, which causes further damage. And there's likewise spasticity and dilation of vessels with plasma leakage, leading to increased viscosity of blood in the microcirculature. And then you get stasis and thrombi. And a lot of the destruction occurs from the secondary vascular occlusion and injury that occurs as a result of this freeze-thaw cycle. So some of the damage is up front from cells swelling and bursting. Most of it is from the vascular injury that occurs in reperfusion. So I put up this chart earlier for heat injuries. There's a similar chart for cold injuries looking at apparent wind chills. So the perceived temperature is a function of both the actual temperature and the wind, which will greatly increase heat loss and increase localized skin cooling. So luckily, Maryland has relatively temperate climate, but we not uncommonly have wind gusts in the 20 to 40 mile an hour range. And once you get down into the teens, those wind speeds are enough to start getting you at risk for frostbite. And obviously, the worse those numbers are, the more rapidly that happens. When you start getting under zero, even a minute exposure can be enough to basically freeze exposed flesh. So with frostbite, initially, as the skin begins to freeze, there is redness in light skin. If there are darker pigmented individuals, the skin will appear gray instead. As nerves are irritated and as those peripheral cold receptors transition to pain stimuli, there is tingling and stinging. And then basically as the extremity begins to freeze, it will become numb, yellowish, and waxy or gray in color, and will feel stiff and almost wood-like as it begins to freeze. If this happens slowly, there may be blisters that develop. If not, blisters typically will develop on reperfusion and thawing. So this is graded in terms of severity and the likelihood of tissue loss. So with a grade 1 or mild injury, there is numbness and erythema. You may see white or yellowish firm plaques in the area of injury, which represent frozen tissue. But the entire digit or the entire extremity is not frozen. And typically this will lead to edema and pain on reperfusion, but will not lead to actual tissue loss. Blistering typically signifies a more severe injury. So small blisters with a grade 2 injury, deeper and larger blisters, which begin to look purplish because they contain blood with grade 3 and higher injuries. So this signifies a more severe injury that can be involved down to the distal phalanx or proximal phalanx in case of a grade 3. And with grade 4, then basically there is freezing down to muscle and bone. And with basically grade 3 and grade 4 injuries, there is going to be tissue loss and may lose the entire limb. So in terms of first aid, obviously you want to remove the victim from the cold and prevent further heat loss as quickly as possible. Remove any constricting clothing and jewelry to try to maintain perfusion to the affected extremity as best as you can. And you want to rewarm the affected area evenly with body heat until pain returns, which signifies thawing and return of perfusion. So as this happens, this is going to be a very painful injury, and the affected victim is typically going to require more than likely IV pain medicine. 2 points to keep in mind. most of the damage is done with the initial freeze and the reperfusion. While the extremity stays frozen, there's not a lot of damage going on unless it's subjected to mechanical trauma. So it is much better to leave the extremity frozen and thaw it out definitively once they're evacuated, as opposed to thaw the extremity prematurely and then have it refreeze because the victim is in transport or is still exposed to a cold environment. The injury will be much worse if there's a second freeze-thaw cycle. The other thing is, it's common folklore, but you don't want to massage the affected part with snow. Remember, there's ice crystals that form in those cells, and you will create a lot of mechanical trauma if you rub or massage the affected extremity because you're physically tearing those cells apart. Likewise, rubbing it with snow will create more trauma and will simply cool the extremity more. And obviously, as you do those things, you want to try to evacuate the victim, get them out of the cold, and to more definitive treatment. Other things that are a little bit more long-term, typically they're conscious, and if available, warm fluids and food will be beneficial, both to warm up core temperature and to increase their metabolic rate. Since this is a vascular injury, if not contraindicated, aspirin should be given as early as possible because it'll mitigate some of that thrombosis that happens in the microvasculature. And if you have it, you want to immerse the limb in warm water, preferably with some sort of mild disinfecting agent at 37 degrees, and maintain that temperature by adding further warm water and let the extremity slowly rewarm. You want to be careful going too hot because you risk overshoot and potentially a burn injury. So 37-degree water, and typically it will take an hour longer for the extremity to rewarm. When color returns, dry and elevate it. Again, no massage, don't break any blisters. Dress it carefully with some sort of sterile dressing and avoid further damage. And then IV analgesia is going to be key. And obviously no smoking, no alcohol, no caffeine, anything that could lead to further vasoconstriction. The other thing is to try to avoid early amputation, because a lot of the tissue that at first glance may not seem salvageable may recover, and you don't gain a lot by early amputation unless the extremity becomes infected. So most of the time they're left alone till they declare themselves. So want to avoid early amputation. Another common injury that you may run into is trench or immersion foot. So here, this is typically happens in hikers who let their feet get wet in a cold environment and don't take care of it. Or it can happen even with dry feet in a very cold environment. But here, this is a non-freezing injury, but the extremities are exposed to very low temperatures in the 50 to 32 degree Fahrenheit range for extended periods of time. And what happens is you get such intense vasoconstriction for a long enough period to where you will get a ischemic injury. And if this occurs in a moist environment for a prolonged period of time, you also get mechanical physical breakdown of the tissues and eventually infection. So initially with a mild injury, the feet are going to look wet, soggy, shriveled, the usual thing that happens when skin is left in water for a long period of time. Eventually tingling and pain will set in, and then eventually numbness. And as this progresses, you will get skin discoloration, and you may develop blisters or skin breakdown and weeping or bleeding. The extremity will become cold, swollen, and waxy. And as this process progresses, tissue will begin to die. So a couple of things. So obviously try to limit the injury and prevent further exposure. Dry the extremities if it's wet. Obviously take all wet footwear, clothing, gloves off. Again, do not break the blisters, do not apply lotions, do not massage because it'll cause more mechanical trauma. Don't expose to heat. And very importantly, because there's a lot of vascular injury that occurs with this, do not allow the victim to walk on the injury. Passive rewarming by exposing to warm air, clean and wrap loosely, elevate the feet to reduce swelling, and evacuate for medical treatment. And again, the victim should not walk on the injury because otherwise they will risk losing their foot. Numbers to remember: if circulation is impaired for more than 6 hours, there likely will be permanent injury. And they may progress to Raynaud's, and they're going to be at lifelong increased risk for more rapid injury on further exposure to cold or wet environment. If circulation is impaired for more than 24 hours, they probably will lose their feet. Last, I'm going to touch bases on hypothermia, which is at the other end of heat and cold injuries from heat stroke, and likewise represents a medical emergency. And this occurs with severe heat loss, and is defined by numbers anytime the body temperature falls below 95 degrees Fahrenheit. So typically occurs in windy conditions because that greatly increases heat loss. And typically clothing is wet and individual is inactive. It can occur very rapidly with water exposure or immersion because, again, water is 25 times as efficient at transferring heat as air. So if somebody falls into water that is 45 degrees Fahrenheit, they will be unconscious and likely dead in an hour or less. Even 60-degree water, which is not that cold, is efficient enough to heat transfer to where a fit individual will survive at best 7 hours. And on land, thunderstorms, hail, rain, wind, all of these things can contribute to hypothermia. So with mild hypothermia, the victim gets what's called the umbles. So they will stumble, mumble, fumble, and grumble. So there will be shivering, initially mild and then become more intense. They will be able to control the shivering with mild hypothermia. They will not be able to control it with severe hypothermia. They will become drowsy, irritable, withdrawn, disoriented. That will progress to confusion and eventually to coma. They will have slowed or slurred speech. They will stumble, and they will have altered vision. So these are the symptoms of mild hypothermia. And of note, again, their sensorium is affected early, and they will lose the ability to protect themselves and realize they're in trouble. So unless somebody's keeping an eye on them, they will not know to put on clothing, get out of that environment, etc. They become helpless. With more severe hypothermia, they will stop shivering. They will have a desire to lay down and sleep. They will become bradycardic and bradypneic, and eventually they will not have detectable heartbeat, and this will be progressed to unconsciousness and then death. So these are kind of the stages and what happens with various temperatures. So even a slight drop in temperature down from 98.6 to 97 is enough to initiate shivering and goosebumps and sort of a very unpleasant need to get out of the cold. At this point, their hands are going to be numb. They're going to be unable to perform complex tasks, and shivering can be anywhere from mild to severe. As they drop under 93 degrees, then shivering becomes very apparent, and they will have difficulty controlling it. Their movements will become slow. They'll become more confused, and they may actually make up for that by becoming hypervigilant. And a simple test is to do a sobriety test, such as have them walk a 30-foot line, or complex math, such as have them do serial sevens, subtracting from 100. If they're not able to do those tasks, then they're in the at least moderate hypothermia range. Below 93, they will have severe difficulty speaking. If they're able to speak at all, they're going to be very sluggish. They're going to be very depressed and withdrawn and not interact, and probably will be unable to control shivering. When they get to 90 degrees, shivering stops and they become incoherent. And below that, they will have muscle rigidity, stupor, very slow pulse and respirations, and they become a risk for fibrillation, which obviously, if untreated, will lead to death. Below 82 degrees are going to be unconscious, and below 80 degrees, pulmonary edema and cardiac and respiratory failure set in. And if they haven't gotten to fibrillation already, they will die at that temperature. So, how to assess the severity. So a couple of things you can do. Again, you can do complex math, serial 7s or serial 9s. You can do the sobriety test. Depending on the environment, other things to consider is altitude sickness, if they're high enough, from cerebral edema, or carbon monoxide poisoning, depending on what they're doing to try to stay warm. Another simple test is ask them to stop shivering if they can. If they can stop shivering voluntarily, they have mild hypothermia. If they can't stop it, they have moderate to severe hypothermia and they're potentially in trouble. If you can't get a pulse at the wrist, that means that the temperature has gone down below 90 degrees Fahrenheit. They're in real trouble and are at imminent risk of fibrillation. And if they're curled up in a fetal position and unresponsive, something else you can do is open up their arms and put them by their side. And if they curl back up, then obviously they're still alive. So that's another test you can use. In terms of cardiac effects that you may see, there's a temperature direct decrease in heart rate, and they will be bradycardic, and this will typically be refractory to atropine. They will also be hypotensive with this to the point where you may not be able to feel a pulse. AFib is common when they dip under 32 degrees Fahrenheit, and asystole VFib is very likely if they get under 25, but may occur as low as 30 degrees. And the EKG, if you have one, will have these characteristic Osborne J waves, which are the secondary positive deflections that immediately follow the QRS. They typically show up when the temperature drops under 32 degrees Celsius. They're not prognostic. It's not that their outlook is worse if they have them versus if they don't have them, but they are a marker that's characteristic of hypothermia. Other things that happen, there's an increase in blood viscosity, and the hematocrit will increase by 2% for every 1 degree Celsius fall in temperature. So that will normalize as you warm them up. But the important point here is that if you have a moderately to severely hypothermic trauma patient and they have a normal or worse a low hematocrit, then that should significantly raise your suspicion for acute blood loss that may be ongoing, because their hematocrit should be higher than normal if it's just hypothermia. They also will become leukopenic, and a normal white cell count does not exclude infection. There will be an increase in coagulation studies that occurs with hypothermia and a DIC type syndrome that occurs. And if you check coagulation tests, because the blood is heated to 37 degrees, they're going to be normal versus the clinical coagulopathy that you will see in the hypothermic patient. This does not respond to clotting factors, and the only effective treatment is rewarming. Likewise, there's a cold-induced thrombocytopenia that occurs that also will reverse with warming. So any sort of injury that can lead to bleeding will do much worse if the patient is hypothermic. Treatments prevent further cold exposure and evacuate them immediately if they're severe hypothermia, because they probably will need invasive rewarming and they're going to be a risk for cardiac arrest. Remove any wet clothing, which is very efficient at cooling them further. If you have a warm sleeping bag available, rewarm them, preferably with warmed bottles of water or saline, again, in their groin and axilla and around their neck. If they're mildly hypothermic and conscious, obviously this doesn't apply to the severely delirious or unconscious patient, warm sweet liquids will help and increase both temperature, core temperature and metabolic rate. And one thing to keep in mind with hypothermic patients is you want to sort of be gentle in how you handle them because of that risk of VFib. Because simple mechanical shaking or trauma can be enough to trigger that, and they're a risk anytime it's under 30. So passive external rewarming should be undertaken for all hypothermic patients and is initial management. So, and this is something that can start in the field and be continued en route. So this will raise temperature by as much as 2 degrees Celsius per hour. So what you want to do again is take all the wet clothing off and get them in a warm environment and apply warm blankets. You can use the aluminum heat reflective blankets as an alternative. And of note, 60% of heat loss occurs via the head. So covering their head and neck with a hat, with a blanket, putting warm bags around that goes a long ways towards preventing further heat loss. This is recommended by the Wilderness Medicine Institute as first aid if you're not able to evacuate immediately. So try to wrap the patient up in essentially what's a thermal burrito. So what you want to do here is lay out a tarp or a clean sheet of plastic on the ground to insulate them from wetness and from the cold ground. And then if you have them, stack 3 sleeping bags and put the patient in the middle one with a sleeping bag above and below. And then put anything warm that you have, again, hot water bottles, hot saline bags, whatever you have around them, and wrap the whole thing up in a tarp. And that will prevent further heat loss and help keep them warm and use the body's temperature to try to rewarm them. In terms of active external rewarming, what works best is actually forced air warming systems, which I think everybody's familiar with bear hugger. And this raises the core body temperature anywhere from 0.8 degrees Celsius to 2.5 degrees Celsius per hour. And this is recommended because it's simple, it's easy to institute, and it's least likely to cause adverse effects. And most of us have been exposed to or are familiar with the Arctic sun, which is primarily used to cool neurosurgical patients, but can also be used to modulate temperature and rewarm. And this consists of circulating water that's basically going to run through pads that are attached to the skin. Of note, this increases body temperature 0.6 to 2.5 degrees Celsius. So it works no better than a bear hugger, but it's another option. There are devices that will immerse the hands and forearms in heated water or heated air that can take advantage of arteriovenous anastomosis reheating. And again, they basically have about the same efficacy of 2.5 degrees Celsius per hour. So the bottom line is, in terms of simple, active external rewarming, forced air warming systems or bear huggers work best. If you don't have any of those things and you do have access to warm water, then you can use that to try to rewarm the patient. But the problem is that obviously limits your ability to take care of other aspects of the patient that you may need to, such as the airway, such as IV access. However, if you don't have anything else, it is better than no rewarming. 2 important points: do not stop rewarming prematurely. And we're going to talk about after drop, but if possible for somebody with severe hypothermia, you want to rewarm the core first. And the reason that is because as they got hypothermic, then they vasoconstricted and limited blood flow to the extremities to try to maintain core temperature. So their arms and legs are going to be much colder than their core temperature. As you begin to rewarm them, they're going to vasodilate, and that heat is going to redistribute. And then what happens is, as the extremities warm, the core temperature is going to drop initially before the patient begins rewarming. And you can get a drop of as much as 7 degrees Celsius, which may be enough to drop them down into the ventricular fibrillation rate. So ideally, for somebody who's severely hypothermic, core temperature rewarming is going to work best and try to prevent this after drop. Despite that, if all you have is active external rewarming. You should not delay that because if you don't treat hypothermia, it's going to be rapidly lethal. Other modalities that are available, airway rewarming, right? If you intubate them, which there's a good chance, you can use warm humidified oxygen if you have it available. It prevents further heat loss, but it does not significantly increase core temperature. It is very ineffective. You can use IV fluids that are warmed to 38 degrees Celsius. You can even go up to 40. But the problem is the patients are typically not hypovolemic. They're going to be a risk for pulmonary edema, so you're going to be limited in how much fluid you can give them. If you do give them fluids, saline is preferable because the lactic acid and lactated ringers is not going to be metabolized by the cold liver and it's going to contribute to acidosis. And you can heat the fluid in a blood warmer, in an infusion pump, in a blanket warmer. If you don't have those things and you have access to a microwave, that works quite well. A couple of caveats. Do not heat blood to more than 42 degrees Celsius because, again, it's a protein in nature, and you're going to form blood clots, which are then going to form emboli. Do not microwave anything that has dextrose in it because it will polymerize to starch and will again form emboli. And this one's pretty self-explanatory. Don't microwave anything in a glass container. Now, for people that are really hypothermic and in trouble, if you have access and where you're transporting them, if you can get them to a center that is able to provide invasive active core rewarming, that gives them their best shot. And the gold standard for this is going to be bypass or ECMO, extracorporeal membrane oxygenation. And of note, patients that are hypothermic enough to go into pulseless arrest will have about a 10% survival rate without ECMO. If you can get them to an ECMO center, especially if it's within 6 hours, their survival rate is higher than 50%. So it dramatically increases their odds. And both these numbers are better than one would think. And part of the reason is that cold is protective for the brain and for the CNS. So people will tolerate hyperperfusion or anoxia a little bit better at very cold environment for a brief period of time. But for anybody that has a temperature under 32 Celsius or 90 degrees Fahrenheit, coupled with hypotension or evidence of ventricular arrhythmias, or anybody that's under 82 degrees Fahrenheit, if you can, you want to get them to a center that can provide bypass or ECMO, because that is their best shot of survival. If you don't have ECMO, the next best, sorry, let me back up on this for a second. So ECMO is very effective and will raise temperature by 3.6 to 10.8. And it can go faster, but the problem is if you go faster, then dissolved nitrogen will actually come out of solution as blood is rewarmed rapidly, and it will get the bends and be a risk for embolic injury to the brain. So the limit typically on blood active rewarming is 10 degrees per hour. So that's why that limit is there. If you don't have ECMO, the next best thing that can be provided is what's called closed thoracic lavage. And you want to consider this if somebody is in hypothermic pulseless arrest and you don't have ECMO available or within the next 6 hours. And it is almost as effective. It will raise body temperature again by 5 to 10 degrees Fahrenheit per hour. So what you do here is put 2 chest tubes in, and you want to use the left chest because the heart is on the left side, and you take advantage of the blood flow within the heart as a heat exchange mechanism. So typically 1 tube goes in anterior mid-clavicular, 14 French pigtail. Another tube goes in basically laterally 4th or 5th left, lateral intercostal space. And you want to put warm saline through that, warmed up to 100 to 113 degrees Fahrenheit. And basically what you're doing is you're using the heart and the left lung as a radiator and as a heat exchange mechanism. And this will raise your temperature up by 10 degrees Fahrenheit per hour, and is the next best thing if you don't have ECMO. Obviously, this is contingent on the patient not fibrillating. If you have neither modality, then you can consider things like gastric or bladder lavage with warm saline. So here, you're basically infusing warm saline again at the same temperature, 38 to 45 degrees Celsius, and then draining it out sequentially. Not nearly as effective, 2.7 degrees Fahrenheit per hour, so it works about as well as a bear hugger. But coupled with a bear hugger may get you a faster rate of rewarming if somebody's in trouble. Of the two, bladder lavage is preferred because it's less risky in terms of aspiration, water intoxication, and everything else that goes with lavage. And that is all I have for right now. So I will open it up to questions.
Very interesting, definitely.
I'll also make the slides available, obviously.
Just as an FYI for people, ECMO centers in Maryland, any center that does heart surgery has ECMO capability.
Yes.
ECMO requires a perfusionist. So Hopkins University, St. Joe, Sinai, Bayview, Walter Reed. I think those are the major ones. PG or Pensacola General. I suspect I might have missed somebody, but any surgery center that can do heart surgery can do ECMO. How about cold water drownings, which is interesting, because that's an acute immersion. It's interesting is when people fall into cold water,
Yeah, that
ice time, they start hyperventilating and then they lose muscle control.
There is a whole. I could easily make another lecture on drownings because it's a whole separate subject. So there's a couple of things that happen there. So one is the heat loss is very rapid. So again, even 60-degree water, you're not going to survive more than about 7 hours. The other thing is the average life jacket keeps your head or your airway only about 3 centimeters above the water. So, it will protect you in still water, but in any sort of waves, you're actively going to have to swim and paddle to basically keep from drowning. So what Jeff is mentioning is what's called cold shock. So when you fall into cold water, there's an involuntary increase in minute ventilation and hyperventilation that occurs within a minute and will last up to about 5 minutes. And it typically occurs with cold water, but it can occur with water as warm as, let's say, 55 degrees. And the net effect of that is you're not able to breath hold. So if you're in a choppy environment and you're not able to paddle effectively, you can't breath hold and you can easily drown before hypothermia ever becomes an issue. And then basically that effect stops, but then what happens is you lose strength and coordination in your extremities and you will lose the ability to paddle. And again, in any sort of choppy water, you will very quickly drown because that life jacket is not going to keep your head far above water. Those things aside, there's the limits in terms of hypothermia. But yeah, that's there's a whole interesting things that happen. One of the more interesting patients from my career that I'll never forget was a young kid that fell into the Potomac in January, got fished out and got sent to us at Children's and showed up with a core body temperature of 83 degrees. That I ended up intubating down in the trauma bay. Succinyl and atropine IM do absolutely nothing when the body temperature is 83 because there is no peripheral blood flow. So I intubated this kid unconscious through clenched teeth as she's vomiting. Luckily got a tube in. And then we spent, 30 minutes trying to get some sort of IV access, a central line and an A line with no pulse whatsoever, to then try to rewarm her. She actually survived, but it sort of got me interested into this topic, and it's a case I remember to this day.
That's one of the things where the saying is no one is dead from cold water drownings until they're warm and dead.
Correct. And legally, you have to rewarm them to at least 35 degrees before they can be pronounced. Let's see. Any other? Sorry, I'm trying to scroll through the questions here. Observation: gut water intake rate explains why every lung runner I've had to deal with has been dehydrated. Yes. Especially marathon runners in a cold environment or in a warm environment are going to become dehydrated. There's no question. And that's where conditioning, their overall health, their cardiovascular endurance, all those things come into play. Acclimatization. And obviously somebody who's trained for this, somebody who has the right genetic makeup is going to do better with that than somebody who is not. I've seen several studies looking at the temperature of long distance runners in the summer, and frequently they're in excess of 105 degrees. So obviously they take a beating in terms of temperature. Somehow they're fit enough to not go into heat stroke. But most people are not going to be that, that tolerant. All right. Oh, let's see, something new.
Does anyone else have any other questions? Remember, if you're looking for continuing education, there is a link in the chat for MIMS CME. There was somebody who put a question about National Registry. You would submit that yourself through the mechanism that's normally done when you apply for continuing ed outside of a program such as like when you do your ACLS cards or BLS cards. Messages.
If you guys are interested, I will send the slides to Ashley and they'll be available.
All right.
All right. Well, thank you, everybody. Appreciate it.
Thank you, Chris. It is always good to talk to you.
Likewise. Good to see you.
It's good to be seen.
That too.
The third year anniversary is coming up. So give everyone my regards over at Walter Reed.
Definitely. And likewise.
Yes, absolutely. And if you're interested in coming back part-time, let me know.
I'm too old. One job is more than enough for right now. I'm trying to work less.
We're the same age.
But thank you. But you look younger.
I'm only 3. All right.
All right. Well, thanks, guys. Appreciate it.
And then we'll finish for the evening. Thank you, everyone, for coming.